Good morning and welcome to Know and Go Friday. I'm Holly Brenner, the Director of Marketing and Public Relations for our system. And I am excited to welcome you what promises to be a very interesting and interactive session this morning. So we've got a few things in store for you. To those of you who are new to Know and Go Friday, thanks for being here and welcome. Those of you who are returning, thanks for that and welcome. I appreciate that you're here this morning. I know how busy everyone's schedules are, and it means a lot to us that you're here. And we're hoping to provide you some real valuable information. Before I introduce our presenters this morning, I would like to share a morning affirmation. Think of it as a challenge, just for today. Decide to be happy today, to live with what is yours, your family, your business, your job, your luck. If you can't have what you like, maybe you can like what you have. For today, be kind, be cheerful, be agreeable, responsive, caring, and understanding. Be your best, dress your best, talk softly, and look for the bright side of things. Praise people for what they do and do not criticize them for what they cannot do. If someone does something foolish or offensive, forgive and forget. After all, it's just for one day. Who knows, it might even turn out to be a great day. So with that, let's check in with our Ripon and Waupun associates. Danelle and Ripon, can you hear us?
We can hear you.
Thank you. And see me? Oh, I don't know if I like that. Shelley, are you in Waupun? Can you hear us?
Yes, we're listening in this morning. Thank you all.
Yes, you'll notice that we are without our normal video conferencing to Waupun today. We hope to have that back as normal for our next session. But this session is being recorded, so make sure to check back to Vital Signs next week if you'd like to see this session, or for anyone who's not here for that matter. There are a number of things on your table. I'll just do a quick review of those things. You'll have the Know and Go Friday overview for next month. We have Dr. Robert Santa Cruz here with the Da Vinci on site, so it's a demo unit. We can take that for a spin, so that should be interesting. We have the yellow card. This is the, what do we call this? Feedback evaluation form. Looking forward to your feedback on that. We really do appreciate it and we value that. We have a Remodel Your Lifestyle program overview, so please take a look at that, as well as a brochure from GI that Dr. Evans will probably touch on that. As a reminder, Know and Go Fridays are designed to help educate you on health topics, you being associates, all of us, and also to introduce the healthcare professionals who provide those services here within Agnesian HealthCare. The more we know about what we do here at Agnesian HealthCare, the better prepared we'll be to share that information. And when you or someone that you care about or know has to use one of our services, you'll be well informed. So today's topic with Dr. Evans, we're talking about colonoscopies, and most people really dread the idea of a colonoscopy. It's maybe embarrassing or maybe it's scary and they think it's going to be painful, but what they might not realize is that having a colonoscopy can be a real lifesaver. And actually identifying the polyps and the precancerous lesions can reduce the death rate by up to 50%. So it's something that people really ought to do. So Dr. Evans is here this morning to help dispel some of the common myths around colonoscopies and cancer screening in general and talk about this life-saving procedure. Our associates Tammy Pitts and Janelle Baldwin are here, and they'll have a cameo later to talk about the Remodel Your Lifestyle program, so look forward to that. Without any further ado, Dr. Evans.
Good morning.
Good morning.
Everybody can hear me? Thank you for inviting me to Know and Go Friday. I wish my mom were here. I'd be like, see, Mom, you can't get a paycheck doing what I do for a living, so I'm glad that you're all here. Today is also kind of a talk, what's a day in the life of a gastroenterologist like? I know people know we're doing procedures all the time. As gastroenterologists, we spend really half of our lives in a clinic setting seeing patients. The other half is spent doing some type of procedure. And I thought we'll touch on a number of the services that are offered here by the gastroenterology service at St. Agnes. If at any time during the presentation you have a question, please stop me. Otherwise, at the end, I'll certainly take any questions that you may have. It's fitting, too, that this is March. March is Colon Cancer Awareness Month, so every year in March you'll hear radio ads, you'll hear, there'll be newspaper print ads, there'll be talk shows that we do, all to spread awareness about colon cancer. Although the numbers are getting better, we're still going to diagnose probably 350,000 colon cancers this year. Roughly 125,000 people will lose their lives to colon cancer. Now, the good news is since we've started doing mass screenings over the last 10 years, we have seen the rates of people dying and passing from colon cancer decreasing. So I think we're on the right track, but there's a lot of work to go, and I'll do everything I can to dispel any fears that people may have about a colonoscopy. Next slide. Our team of gastroenterologists, myself, Dr. Kylas, and Dr. Slindy, that's 41 years of practice right there. We've all been here for quite a while. Prior to this organization having gastroenterologists, the surgeons did the procedures, and there are still 6 general surgeons that do a fair number of endoscopic procedures in the GI lab. You might not know that both pulmonologists, that's where they'll do their bronchoscopy scopes into the lungs is up in the GI lab. You need to have a negative pressure system or room so that you don't spread infection outside of there. When we built the GI lab in about 2001, we thought that was where we had the best room capability to build that negative pressure room. So that's where all the bronchoscopies have done since that time. I'm very proud of the staff of the GI lab. You know, for 3 doctors, you think, geez, they have 25 support people. And that's really what it takes in order for us to have a very well-oiled, efficient system. When you're doing gastroenterology, you're doing the same procedures over and over and over, and you need to become extremely proficient, and that helps the patient has less time to feel vulnerable, and just we get the procedures done. The patients, we hope, are in and out quickly, and it's as minimal a disruption to their day as possible. But we have 17 RNs, 2 LPNs, 4 CNAs, and 1 operator front unit person. And next. And there, the gray hair attests 41 years of experience sitting right there as of a couple weeks ago. When we designed the GI lab, we designed it so that you would walk in the front door and that we could go in a circular route one way or the other to increase through fare, meaning that we never had to retrace patients' steps, that we could admit into one room, get their paperwork done, admit them into the system, bring them into the procedure room, do the procedure, out the other side of the procedure, and then into one of the 10 to 20 recovery rooms that we have to recover for an hour or so before they go home. All of our rooms generally, for the most part, have their own private baths. They have TVs. They're very comfortable for the hour or 2 that you're going to be spending there. We have, I think, about 46 working instruments at any one time. And Kim here is washing a scope. The instruments, whether we use them or not, all have to be washed to a high level of sterile disinfection once a week. And so we actually probably have 2 people whose sole occupation, the nurses will take turns doing it, but that's all they do is clean instruments day in and day out. I mean, it's a lot of volume that passes through those doors. The procedures that we do here, the most common ones are going to be colonoscopies, or a look at through the large intestine, and then the second would be upper endoscopy. Now, we also do a number of niche procedures that may make us different from other GI labs. I do something called radiofrequency ablation, Dr. Kylas and I do, and that's a treatment where we now, for the first time, can eradicate or destroy somebody's Barrett's esophagus, which we're going to talk about later. And Barrett's esophagus is a precancerous condition of the esophagus. Esophageal cancer month is next month in April, so maybe I'll come back and do April talk too. We also do, not every GI center does this, we do a fair number of what's called an endoscopic retrograde cholangiopancreatography. ERCP. That is a procedure where we go up into the bile ducts, and we oftentimes are doing this in association with somebody having their gallbladder removed, or sometimes we're treating cancers of the bile duct or pancreas. And sometimes we'll use a procedure like this. We can, if there's been a complication after a gallbladder removal and a bile duct has been injured or a clip has been displaced, we can save a patient a second operation by going in there and being able to do what we do with the scope. All of the procedures that we do there's no, if everything is gone right, there's never an incision on anybody's tummy. Everything is done through the mouth or another orifice, and so people are always told you won't wake up with any scars from when we're done. About 10 years ago, capsule endoscopy came out, and we will show one of those today. That is a large vitamin-sized pill that actually takes 2 high-definition photographic images per second. And that allows us to look at somebody's small intestine and other areas of the intestine that we really can't reach very well with the scope. And that's useful to look for obscure sources of bleeding, abdominal pain, and certain types of cancers. Endoscopic ultrasound is simply ultrasound that is affixed on the end of a scope. It allows us a very high-definition view of a tumor so that we can more accurately stage that for our friends in the cancer center before somebody would undergo surgical treatment or chemotherapy. Esophageal motility, and these again are all studies that most GI labs will do. We, I think, do have what I view as top-notch equipment in all of these areas. Esophageal motility is a way that we can measure the pressures within somebody's esophagus. There are certain diseases where people lose the ability to have their esophagus contract, and sometimes before Dr. Stanley or Dr. Reynolds or Dr. Moen would do a surgery to fix somebody's heartburn, they'll need to know that somebody's esophagus swallows well and it's not going to be a problem after surgery. Bravo pH study is a little computer chip that we'll put in the esophagus, and we'll show you examples of all of these later, where it allows us to determine the pH in your esophagus for a 48-hour period of time while you're just wearing a belt pack and going on with your normal life. All of these things, 5 years ago used to be wired procedures. You had wires coming out of your nose, wires going down to the belt, and people really would just sit in a chair and do nothing for the next 48 hours, and you really don't get a very good test result. Now that everything is a wirelessly transmitted procedure, we can do these things and people will go on with their normal life. So I think we can get much better estimates as far as, is this the source of somebody's chest pain when they're known not to have any heart disease? Is it because they're having bad reflux? And next slide. Right now, the GI lab does about 6,000 to 6,500 cases per year. This is last year's data. We did 3,800 colonoscopies and about 2,300 upper endoscopies. On average, when you look at day in and day out, the GI lab does about 30 procedures per day, or 30 different patients are admitted and discharged through the GI lab. We start doing procedures at generally about 7 in the morning and then really don't close up shop until 5 o'clock or later whenever the last ones are done. I think if we can go to our next now some of these things, I'm going to just show you some slides of some things. You can just hold it for when you get there. About what we're actually doing, and because for patient confidentiality, I get all my videos off YouTube because they're not protected and they don't show anybody's names. So if this is disgusting to anybody, look down and it'll be over in a few seconds. What you're looking at is a large polyp in the colon. And that is, certainly we're magnified here. In real life, that is probably a little bit bigger than walnut size, okay? It's not grapefruit size, okay? So, the only reason we even have grapefruit is so people can have something to compare the size of their tumor to, okay? So if anybody says they had a polyp the size of a grapefruit, that's wrong. How do we get a polyp? A polyp starts out as 2 genetically imperfect cells. And all of us have genetically imperfect cells. Our bodies have a great system of policing these cells and taking them out of existence. But with breast cancer or with colon cancer, we have 2 cells that are imperfect, and those 2 cells become 4 cells. These 4 bad cells become 8 cells. And for some reason, our body's genetics that are supposed to be able to detect and remove these cells, it slips through the cracks. And we get more and more of these cracks as we age, partly because of genes that we're born with, genetic barriers that we hit during life, foods that we eat. All of those decrease our body's ability to fight off these cancerous cells. It's actually pretty well designed data. We know that it takes about 12 years from the time a polyp starts until you get a colon cancer. This is a polyp that is probably in that 10-year range. Okay. Now, the one good thing about having a long time frame is that it gives us plenty of time to go in and do a colonoscopy and remove a polyp before it becomes cancer. I would say 95% of the colon cancers that we diagnose upstairs are going to be in somebody's very first colonoscopy. When they've never had one before, you know, we'll get people that come in their 60s and 70s for a first procedure, or and you cannot wait until you have symptoms. If you wait till, yeah, I have blood in my stool, or I'm having belly pain or weight loss, more than likely it's too late and the disease has progressed. You know, you want to, hopefully we catch these. This is still a very treatable disease, because even if there is cancer in this part of the polyp, you're going to see it's on a long stalk, and there won't be cancer in that area. So now we're just going to let this roll through a little bit. Okay. Now what they are doing, that blue loop is around the polyp, and that's called an endocinch. And that is a device that we can just basically choke off the blood supply to it, so we know it's not going to bleed all over when we're done taking it out. And let it run. Yeah, just go ahead and let it run. Okay, go to the next, yeah. Okay, so now that now you've passed a wire. Okay, so that's the blue loop that's going to choke off the blood supply to this thing. And now if you forward to our next. Great. And now if you, right here, what you're seeing, this braided wire actually is a lasso that goes around the polyp, and it's going right onto the neck area of it. And now you're going to pass cautery through it, and you're going to cut that polyp off so you can let it run. And this is a very typical, and stop it, that's how we remove a polyp. Okay, so now this polyp, this is too big to remove with the scope. A lot of times small polyps will just suck through the scope into a collection system. This one we have to drag out. But what I wanted to show you here is, you know, this big polyp, that's all you're left with, is that little divot there. In a 1 week's time, you won't even be able to see that. In fact, oftentimes people can get their first tattoo with us at any time, because we'll inject ink into the wall so that we can always find that area. So people can get inked in our division as well. The base here is normal tissue. If there is cancer there, this person's now cured with just the colonoscopy. In a period of there's a small risk of bleeding after a big polyp like this has been removed. That risk goes on for about 10 to 14 days total. Okay. And so that was a polyp being removed. Thank you. That worked nice. This is our scope locker, and it looks like we've got some things out for repair. All the instruments are expensive. They have to be.
Does that clip that you put in there, does that just stay there? Does it dissolve?
No, what'll happen, that clip, as the that little butt end that we saw sticking out, that will retract into the wall of the colon, and as that retracts back in, it will push off that nylon clip, and then you will pass that out and you'll probably never see it.
Thank you.
Yeah, so anything like that, please ask, because sometimes I forget. I don't know where these things end up, but we usually will start doing procedures at age 50. Now, African American, the recommendation is to start at age 45. They have higher incidence and actually, for unknown reasons, have worse characteristics as far as the time of presentation and have a worse response to treatment. So everything leads to us starting sooner. Procedures are usually done every 5 to 10 years, and it depends on if we're finding polyps or not. It is an outpatient procedure. It is generally done with moderate sedation, but can be done all the way up to general anesthesia. Very rarely do we have to give people general anesthesia. We do many cases, probably 5 to 8% of our colonoscopies are done with the assistance of the anesthesia service, and they, with the concoctions they use, can keep people absolutely comfortable if needed. If any polyps are removed, it's usually about 5 to 7 days before you would have either an appointment or a letter from the group saying what the polyps showed and when we need to do this again. And next slide. A little bit of history. Dr. Hiromi Shinya was at Columbia, New York University. He came here from Japan. He was actually already a neurosurgeon in Japan, but he wanted to leave Japan and come to the United States. He couldn't get any type of fellowship in neurosurgery, so he accepted one in internal medicine and gastroenterology. When he got here, a research project that he was working on was Olympus, the same Olympus that makes your cameras, had developed a fiber optic upper endoscope. And back in the day, a fiber optic scope contained about 100 bundles of just very small diameter flexible glass rods encased in vinyl, and then light would shine through one end, and it was kind of like a kid's periscope in that it allowed you to see around corners and through something. And he started playing with that to see if he could manage to work this in the colon. Now, it didn't hit the mass market until probably 77, 78. The surgeons here, Tom Carlson and Tom Freeman, who many of you may know, they were the first doctors that did colonoscopies here. And I talked to Carlson yesterday, and he said he thought it was in '85. But that's, I kind of am into history. Let's see. The song in 1970 would have been Lola by the Kinks. It would have been Come Together by the Beatles. Those would have been, and Stairway to Heaven would have started a couple months later. So that takes you back. You think that's old? Last night, you want to see a bunch of old people, go to a Bob Seger concert. I went last night, and it's like, okay, where is the assisted living vans? Where are you hiding? Because, and Bob's like, I bet you don't remember how old that song was. And it was 1968. What some of his old music was from, and it's like, oh my God, when did we all get old? When I first started here, we had 2 dinky procedure rooms, and there wasn't even enough room in those 2 rooms. You had to take the patient's gurney out in the hallway and turn it around and then put it back in because there wasn't enough room to spin the beds. We had to be done and out of here. The dictation station was an old telephone booth. Okay, if anybody remembers that. We had to be out of here by 5 o'clock because Narcotics Anonymous had meetings on Tuesdays and Thursdays. So the day had to be done by then, and we had to have all the patients out of there so they could come in and have their meeting. Between every case, the nursing staff had to wheel the patient down to the old OR recovery area, and we figured it was like a 200-yard round trip. And so everything would just come to a grinding halt between each case. Jim, you've got to remember those days. Now, And when we built this, and up until a few years ago, and it probably is the same, we had the largest GI area outside of Milwaukee. It had 6 procedure rooms. I guess that's still the case now. You could say maybe 7. It gave us the ability to have 20 patient recovery beds, and allows us to do many more procedures than we could back in the day, such that we now can do 30, 35 procedures a day. 35 is a long day, but we have days like that. Next slide. People are always worried about, is this colonoscopy going to hurt? And what we'll always tell people, it's not the procedure. The procedure is the piece of cake. The bowel prep is not much fun at home, and you kind of have to push yourself on that to keep drinking, even though you're feeling bloated and terrible, and I can't drink, I hate Gatorade, I hate Jell-O. But the procedure part's easy. We're going to give you these fast, short-acting amnestic medications where our greatest compliment is when people wake up and we get the, are we going to start this yet? And it's like, we're all done. You're in your room. And patients don't remember any bit of it. And that's actually, we are always striving to provide the maximum amount of comfort. And I would say, 99% of people they're asleep through the whole thing. They don't remember anything. Some people actually prefer, I have several people that want to go to work and they don't want sedation, and it's a procedure that I can do without sedation if people say, I don't want any of this medication in me. We do always offer deep sedation and general anesthesia for those that are on a lot of other medications or have other complex medical problems that we're worried that they wouldn't be comfortable. We're certainly, any patient, we always encourage patients if they have any concerns about how they're going to be sedated to bring that up and talk to us, or their primary provider, and we'll always make accommodations for that. And next slide. One of the most important things is that bowel prep thing. How well do we clean out the colon? And that is something that we actually grade ourselves on, and I think in the future others are going to be grading us on, is how well these colons are prepped. We have a system that we think is reproducible about how clean a colon is, because how clean a colon is determines how well I can see, how well I can find polyps, and how well I can save somebody from having complications of colon polyps. We will give you instructions about days before. We usually put people on a lower residual diet, more liquid diet. There's always telephone numbers on all of the paperwork. There's always a gastroenterologist on call. Usually at night when you're on call, you'll get at least a couple of phone calls about questions about bowel prep for the next morning. So always tell people there is always somebody on call if they have any questions about what to do with that or their other medications. And just drink and drink and drink and drink, and that's the most important thing with a bowel prep. And next slide. And it's, it's the difference between seeing on a snowy, foggy day and being able to see in bright sunshine when we're doing these procedures. And next slide. We think if there's a lot of different ways you can look at these numbers. I mean, you're going to have 125 to 150,000 deaths. We think that we could definitely cut that down to only 30,000 if we were doing a really good job with screening. And despite the fact that this is the gold standard test for diagnosing colon cancer, compared to mammography and other screening methods, typically in women, we're not doing as well. Some studies are saying that we're only evaluating 60% of the people that we should. I think a lot of it's a grassroots effort. We've got to get out there and convince people that this is not a bad thing. And facilities like ours, there's no embarrassment to this. They do so many of them up there. I tell people, I doubt your butt's going to be the best I've ever seen. I doubt it's going to be the worst. And there's 20,000 in the middle that nobody, so it is a piece of cake. And next slide. When we're doing an upper endoscopy, we're kind of switching gears now. We're looking at the esophagus, stomach, and the duodenum down into the first part of the small bowel. And that is, oftentimes we're looking for a disease called celiac disease. And I wanted to mention that briefly. Celiac disease is a very common, up to 5% of the US population has it. It's a disease where we can't break down wheat products, and there is a celiac disease support group here at St. Agnes, and you may, and not a lot of people know that. Celiac disease in kids can cause anything from small size, short stature, diarrhea, anemia, irritability, fatigue, doing poor in school, false diagnosis of ADHD. All that stuff has been attributed to celiac disease. In adults, celiac disease is it's a big misnomer. It can be crampy, irritable bowel complaints. It can be, why did I have a compression fracture at 42 when nobody else in my family has bone issues? It can be, why am I losing my hair? Why am I gaining weight? Why is my thyroid not working? All of those are potentially causes for celiac disease. A trip to the dermatologist, oftentimes a lot of skin conditions are related to celiac disease, and oftentimes a dermatologist can just look at it and say, well, do you have celiac disease? I mean, very, very common disorder. Other things that we're typically looking for are people who have chronic heartburn or reflux. Probably about once a week we will have to come in and remove a piece of swallowed something that gets stuck in the esophagus. That's a very common procedure that we do when we're on call. We're also doing many evaluations for abdominal pain. I feel bloated. I don't have much appetite. And then we also will place stents into the esophagus for esophageal cancers. I brought some stents around, and people could just pass those around. Those are a variety of metallic stents that we use, a little bit bigger in size, but generally the same principle of what's seen in cardiology. Those, when you get them, if you kind of stretch them and turn them, they get really narrow. Don't get your fingers stuck in there, because I'm missy. You go playing the Chinese finger trick, I'm leaving you. They come wrapped up on a catheter really tight, and then it's like exploding chicken wire. As you pull the ripcord, all of a sudden the stent blows out and holds it in place, and that's how you put in a stent. And our next little video, please. This is going to be treatment of a bleeding ulcer. And what you can see right here is there's a pretty good pumper in the stomach, and that's something that we would get called into, somebody passing a large amount of blood. In the old days, this was a trip to the operating room, and now most cases are be able to be treated with endoscope. Into our next spot. Now, what you're seeing here is actually a metallic clip, and these are what we're going to do is we're going to reach down there and we're going to grab that bleeding area and we're going to fire off this clip. Again, that's quite magnified. That clip, when it's done here, is probably a 1/16 of an inch in diameter, maybe 1/2 an inch long. And I don't know, to our next one. So that's what it looks like when we have clipped a bleeding vessel. And we'll use clips. There's a lot of different ways and toys that we can use to stop bleeding. Clips are one method. Sometimes we'll inject medications. Sometimes we will inject medications. Sometimes we will cauterize and burn, and there are just several different ways, the clips being one. That clip will fall off in a couple of weeks. And next. Barrett's esophagus, as I mentioned, that is a precursor to esophageal cancer. Typically what you're going to see is over time people have reflux changes where you get these small ulcers there. Your esophagus is trying to protect itself from the acid, so it starts to grow abnormal tissue in the esophagus, and that's that darker pink tissue. And then finally, after several years, that's an esophageal cancer, and that's what we're looking to prevent with all of our strategies to treat reflux, is trying to prevent people from getting to that point, because at that point, options aren't good. It may be stenting, it may be a very big radical surgery that has a bad prognosis. And next slide. You know, we think average age when we diagnose people with Barrett's esophagus is 50 years. They will have typically had about 4 to 5 years of steady 4-time-a-week heartburn. Those are the times that we want to step in and offer endoscopic treatment or at least diagnosis. A lot of times by the time people hit 50, they really don't even have the same types of heartburn and reflux complaints that they would have had when they were younger. So the take-home message is you don't ignore heartburn and you don't ignore difficulty swallowing. Those always need to be evaluated. And next slide. Now, how we diagnose Barrett's esophagus, there's no x-ray test or anything. It has to be obtaining of tissue during a procedure. An upper endoscopic evaluation is much easier than a colonoscopy. It's roughly a 5-minute procedure. Again, you are sedated. You will always be able to breathe. You will have no recall of the procedure, much like a colonoscopy. People are always worried about coughing, choking, gagging, not being able to breathe. That does not happen at all when we're doing an upper endoscopy. Reasons why we really need to look for Barrett's esophagus: when people have had this 3 to 5 year history of having acid reflux, or when there's a family history of esophageal cancer. What's real nice now is that here we have the ability that we can get rid of this Barrett's esophagus. We have a very effective therapy called radiofrequency ablation that we started doing a couple years ago. And we've had really, I think, very good results, and I'm always looking at expanding that service because it's one that needs to be available and it's not universally available here. And next slide. And this is just a little cartoon that it's a special balloon catheter, and next slide, that we put into position over this Barrett's esophagus. We run electricity through it, and what makes this system work is it only burns a very minimal depth into the esophagus. It's enough that we can burn all the precancerous cells out of the esophagus, but not so deep that we end up injuring the underlying esophagus or causing complications. All of the previous treatments, that was the biggest problem, is that it caused so many complications. I don't really think we solved anything. And next slide.
Is that something you have to retreat then after time?
Typically what you'll do is you'll do procedures every 90 days. And it's taking me now on average about 1 to 2 treatment sessions before I can say I've got it all burned out of there. And then after we've gotten it burned out of there, it will be surveillance biopsies to just make sure all the tissue's gone. And that's something that's evolving in the industry and with what I do as far as how, and we are lengthening out the length of time as we become more comfortable in the US that we've completely cured these people. And we are treating these people right up until the point of having esophageal cancer. So, I mean, we're doing pretty high-risk patients. Yes?
Is there like a subset of patients that certain criteria where they can't have the ablation done?
Yeah.
Dr. Evans, could you repeat the questions for our Waupun and Ripon?
Is there a subset of patients who are not candidates for this procedure? You know, it is marketed, and this was like the first thing that was FDA approved the second that it came out, because the prognosis of living with esophageal cancer is so terrible, and we have no chemotherapy, and our surgeries aren't good, and our long-term survival is terrible. This was automatically approved. Right now, insurance companies are looking more favorably the worse dysplasia you have, the closer that you are to cancer. We've had some patients that would fit the criteria for having the family history and the long segment, and they're young men. And young guys between the ages of 43 and 50 are the highest peaking group of esophageal cancer, and it's a scary rise in how much that's going through the roof. In time, I think in 5 years, I think anybody who has Barrett's esophagus, I think it will now be that that's covered. I think I'm going to look at this like colonoscopy, and at first you had problems getting colonoscopies covered. Over time that's gotten easier and easier. I think over time it will for Barrett's, but right now If you had no dysplasia and it was a short segment, some insurance companies are not going to pay for it. The other thing, there is data, and this needs to get out there. If this works as well as we're saying it will, it becomes cost effective for us to remove the Barrett's rather than us to just keep looking every few years and double checking and never doing anything to get rid of it.
Is this the Halo procedure?
That's the Halo procedure. That's the trade name, so I didn't use it. There's now one going to be called, it's a cryotherapy one, which if you failed Halo, we would freeze it out. And that's next on the horizon. Moving on to ERCPs, and I can pick up the pace here. This is a test that we use to diagnose and treat diseases of the pancreas, liver, bile ducts. It gives us a way that we can get up into the bile duct and remove a stone. That's the most common reason we do it. Oftentimes we might be opening up a blocked bile duct or placing some type of drain. Typically patients would come in yellow and jaundiced. That's the procedure that we're doing. We don't do as many of those as I like. Probably do 150 a year, something like that, on a good year. And next slide. Capsule endoscopy, and we're going to pass a capsule around, and everybody can look and hold and touch that. It's just the white part, not the blue part. The patient swallows that, and it takes 2 images per second. It's a high-def camera that the battery pack in the pill lasts for about 8 hours. And so I'm going to get 60,000 images all the way from the nurses taking pictures of themselves before you swallow it to other stuff you don't want to hear about, to and you don't have to recover that and bring it back to me, okay? When it goes, it's done. And all of those images are relayed wirelessly to a battery pack, and then we sit and watch a movie about what it looks like. And the reason we're doing it, it allows us to look at your small intestine. It allows us to look for conditions of low blood count, cancers, things that we can't see when we do a scope procedure because there's too much small intestine in the middle we can't reach. Okay. And this is an ulceration, a circumferential ulceration. That's what you might see with Crohn's disease. A lot of medications cause ulcerations of the small intestine. This patient had been anemic for a long period of time, requiring blood transfusion. So this is a way that that you're not going to see on any type of CT scan or any other imaging studies. So, and next slide. Endoscopic ultrasound, that gives us the capability to do fine, high-quality detection on growths to try to determine as accurately as we can the stage of disease at the time of diagnosis so we can best have the best treatment available, whether that would be surgery first or whether chemotherapy first and radiation first. It depends on how well and how accurately we can stage. So a lot of these diseases, you don't want to put somebody through a huge surgery if you knew that there was no chance you were going to cure it. And patients need to have the ability to make that decision. Endoscopic ultrasound helps us do that. And next slide. We do motility studies, and that's to help to evaluate motor abnormalities of the esophagus. Those are uncommon conditions, but we do have all the necessary equipment that we can do high quality studies in that area as well. Next. A Bravo pH monitor. Marge is going to pass one of those around, and that is a kidney bean sized pH probe that I can attach into your esophagus, and it's going to give me pH readings in your esophagus for the next 48 hours. And that allows us to try to determine why you have chest pain. It allows us to determine why our heartburn medication is not working for you. That's quite an advancement over what it used to be when we have to have wires going through the nose and a belt pack. That people could do their normal activities. And that actually, the little brown bean thing on the end of that actually gets snapped off onto the esophagus. Next slide. And all that you're left with is this little kidney bean shaped thing that's attached to the esophagus. That will stay attached for about 10 days, and then that falls off, passes in your stool. Next slide. And that takes us to the end. Does anybody have any questions about anything? How soon would we screen if somebody has had gastric or esophageal erosions? Would be generally in 5 years. And that's mainly because the medicines that we use are so effective in shutting off the acid in the stomach. And the acid does do some good things, so we just want to make sure that people aren't developing Barrett's changes or other bad things right under our noses while we were treating them with these very potent medications. We didn't talk about it today, but there's now been some kickback that some of these medications, like the Prilosec, the Nexiums, the Omeprazoles, the Previcids, that those really have some bad side effects. And I think there's a concern that we need to be careful when we're using these. Even though they're available over the counter, people can do a lot of damage. Especially the rates of hip fracture, compression fractures, things like that are so much higher when people are taking them. Any other questions? Yes.
What is your take on food as far as organic?
I'm sorry, I'm too much noise up here.
Take on organic food. Your take on organic food.
You know, you hear everything.
Yeah. I know organic foods are not standing up. Really, a few months ago, they found no changes as far as health quality, things like that. I think people who eat poorly, I mean, we can say that there's a correlation between high-fat diets and colon polyps, high-fat diets and reflux, and high-fat diets and esophageal cancer. So I guess that's eating well does pay from that standpoint. Now, we use a lot of probiotics for many different conditions, and I think they're very useful. There are several varieties out there. Some people like what's in yogurt. Some people like the many different varieties you can buy. They definitely have benefit, and we use them a lot more now than we did 5 years ago. Okay, yep. So we thought what we have, Jim has been so kind to volunteer. We have an Olympus training model that Jim is going to try to do a colonoscopy on.
Go, Jim.
And I don't know, how many golfers in here?
Please put your gloves on.
How many people bet on the golf course? If you're not going to bet on the golf course, don't play. So the bet is, if Jim can get to the end of the colon in 3 minutes, I'll write a big check to you on behalf of you guys' name for some program of your choice. If Jim can't get to the end of the colon in 3 minutes, then Steve Little's going to buy you all a water bottle. Okay? Okay. So we have a monitor here. Got gloves. We got the plastic bum insert. And
We ready to go?
I'll get some gloves on.
You want us to cheer you on, Jim? Let's stay quiet so you can
You can cheer me on. Ready to go or no?
Yes, it is ready to go. I believe it's there.
A little lubricant. You need some more.
Now, you can't believe how many tens of thousands Olympus would spend on developing a training model, and you can put in all sorts of trip-ups to make it harder. Now, we've taken them all out, so this is as easy as it gets. Now, the wheels on there, Jim, the small one makes your left-right movement. The bigger wheel does up-down. Okay? So who's my timer? Are you my timer? What should we give him? 3 minutes? 4 minutes? What do you think? 3? Okay.
wheels do?
So the wheels, yeah. So there, if you look it up on the screen, there you can see what you're looking at there, okay?
Okay.
Okay.
And then you just advance it with your hand?
Then you advance with your
Oh, I
hand,
see.
and then you use the wheels
To visualize?
to visualize, okay?
Gotcha. Okay.
There you go. Oh, look. Oh, now you got it flipped over. I don't know what you did there.
That's when the patients go, oh.
Yeah.
Well, they're sedated, so.
Yeah, they're sedated. You eat with those hands? Lord. Oh, no, you're doing great. Remember I said 99% of people are well sedated for this procedure?
General anesthesia.
Jim, what are you seeing in there?
Now, to be fair, he's using it. There's two techniques. The way I do it, and then there's the force, and that's what he's doing. Following the force. Yeah. I know somebody.
Oh, lots, yeah. We got those taken out.
Here, I'll get you up a little ways, and yeah, I'll give you a little help here. Maybe it's broken. Okay, there's problem number one here. Okay. There we go. Oh, wow. There's the...
Yeah, there. You can see it.
Christ, I can't even do this.
Yeah, get in there and help them.
Okay. All right, Jim.
There we go.
There, I put you up 3/4 of the way.
Okay.
There you go. Now you're seeing. And if you're looking at a red wall, back away. Yeah, Marge, help him out there. Make the colon fit him.
I want Marge to help me with mine. It's called abdominal pressure.
10-second warning, Jim. 10 seconds. Low pressure.
One more heave.
Not so hard.
Should we put him out of his misery? Time's up. Jim.
There you go. We in?
So, everybody gets a water bottle and you get a donation. Yep, I'll make a donation. Well, thank you
I
all.
was doing it for all of you. So.
Well, thanks, Jim, for being a good sport. Thanks, Dr. Evans. That was a great interactive presentation. Sorry, a little close here. We were scheduled to do a little bit of information on Revital Your Lifestyle program, but due to time, we're not going to do that today. But there is a table outside, and Janelle and her team will be out there explaining the program. She's in the back. So please remember to fill out your comment cards. We really appreciate that feedback. Has everyone had an opportunity to enter their name in our drawing this month? Yes?
Yep.
Terry, what can we win today? Besides a water bottle.
Besides the water bottle, you have another water bottle, a big one. Actually, what this is just a duffel bag full of Agnesian items. We have the duffel bag with the Know and Go. I'm sure all of you are familiar with the Know and Go. Hope all of you are trying to make those healthy lifestyle changes. We also have a nice polo, actually 2 nice polos. We have a yoga mat. Just a lot of things to keep you healthy. Okay, so what we're going to do is we're going to go ahead and have Dr. Evans pick the winner. Deanne Thurmer from Wapama Memorial Hospital is the winner. So it looks like we'll probably be sending this over to Deanne, so congratulations.
Thanks for being here this morning and have a great day. And work on our affirmations. Be happy. Thanks.